This is a quick review of tendons in the digits. Looking volarly, we've got the FDS sitting superficial to the FDP until the FDS bifurcates. From that point, FDP will sit superficial to FDS. FDP will insert at the base of P3, and it's the only muscle tendon unit that's going to flex the DIP joint. FDS, after it splits, is going to reunite under the FDP. That's called Camper's chiasm, and it's going to insert at the base of the middle phalanx, and that tendon contributes to PIP flexion, but the FDP is also assisting with PIP flexion. Then the intrinsics are contributing to the lateral bands. We've got the lumbricals and the interossei that help form these lateral bands, along with the EDC, because the EDC is going to split into three. It's going to insert at the base of P2, but then it's also contributing to the lateral bands. The light blue, those are stabilizing structures, the sagittal bands and the dorsal hood that both centralize the EDC, the transverse retinacular ligament that keep the lateral bands in position, along with the triangular ligament that also stabilize those lateral bands. The other structure is a ligament as well. It's the oblique retinacular ligament. It's going from the volar plate of the PIP joint to the terminal tendon, and this basically coordinates the IP joint motion. So when the PIP flexes, it makes it easier for us to passively flex the DIP joint. If there's scarring or tightness, you can assess for that by maintaining PIP extension. That's going to keep this on stretch, and then assess for passive DIP flexion. And if it's reduced, then that implies that that ligament is tight, and so you can do the test position as your intervention to stretch the ORL.